So when we're talking about epidemiology, right, we're talking about the study of cancer's prevalence in a population and how it spreads, right? So for instance, if we look at cancer occurrence, right, we're taking cancer, and this is just a diagram when we look at the epidemiology, and the different types of cancer, the common ones anyway, that tend to impact individuals as a whole in our society. Right, one of the things that we look at in epidemiology is risk factors, so things that put people at risk. When we're talking about cancer, we break it down into environmental, right, things we're exposed to, and behavioral, things we do. We already know if somebody has genetic history out of it, or family history, then they're at risk, right? So we're talking about things that are going to increase that risk more. So things that cause risk factors are under the environmental category. Things like ionizing radiation. So their overall exposure to radiation in their lifetime. Certain occupational exposures, things they might be exposed to like chemicals, gases, things like that as part of their job. If they're immunosuppressed because of any other disorders or problems, issues that cause chronic inflammation for individuals, if they've ever had chemotherapy before, been exposed to heavy metals or other toxins or viruses or bacteria. So for instance, if people get HPV, right, women, they're at increased risk for cervical cancer. People who've had Epstein-Barr or mono are at increased risk for different types of cancer than others, right? Behavioral are things we do, and this is pretty common knowledge anymore, right? So things that make people at increased risk for cancer. Of course, tobacco use. We most prevalently think of smoking, but any type of tobacco use can be harmful for us. So people who tend to chew or use even smokeless tobacco, they're going to be at increased risk as well, right? Alcohol intake, poor diet choices, obesity or lack of exercise, people's exposure to light, especially for skin cancer, and then if they just follow closely to their cancer screenings or not. Right, so let's talk about tobacco. This accounts for about 30% of all cancer deaths in developed countries. It's linked to more than just lung cancer. It's highly linked to cervical, head and neck, bladder, liver, pancreas, uterus, all types of cancer, all right, as well as lung cancer. When we look at cigarettes, right, there's about 40,000 chemicals alone in cigarette smoke, right? 250 of them are known to be toxic, and 60 are carcinogenic or cancer-causing, right? The earlier people start smoking, the higher their cancer risk is, especially if it was in their teen years, because that's when they're still developing, right? So they're essentially putting carcinogens into their system at a time when their cells are still developing and growing, right? So that increases their risk. Secondhand smoke is also highly carcinogenic. This is why we care even if people don't smoke, if they're exposed to smoke in their homes or in their jobs. And then we even are looking at third-hand smoke, so exposure that people leave whenever the scent and the chemicals from the smoking is on their clothes, and they go out and they have contact with their kids and things like that. When we look at diet, there's foods that are cancer preventing and foods that are cancer promoting. Right, so some foods that are cancer preventing, not surprising, things like fruits and vegetables, high fiber foods, they help to prevent cancer. Folic acid also plays a role in that. Lycopene is a natural chemical that's found in things like tomatoes. You might even see it on your Heinz ketchup. For a while there, they were advertising contains lycopene on their labeling. Green tea is also cancer prevention food or drink. And then things that are thought to promote cancer, charbroiled fats or meats, proteins. And that's because if they're charred or burned, then they contain a chemical compound called polycystic aromatic hydrocarbons. Alcohol. Overall, our Western diet is not very good because it tends to be high in fats and low in fiber, things like that. Fried foods, high levels of calcium, and then foods that are high on the glycemic index. So you may have heard of this if you're familiar with diabetic diets, but foods high on the glycemic index tend to be full of simple carbs or simple sugars. They break down quickly and increase the glycemic index, or your amount of sugar in your blood supply, quickly after you eat them. Right. Other foods that can be cancer causing, aflatoxin. This is actually a mold called Aspergillus flavus. It's often in grains, nuts, and vegetables. It's very common. We care about it whenever it gets too high and it's tested. Right, for instance, peanut butter, it's okay as long as it has less 12 parts per billion. So there's probably already some in our peanut butter that we eat. It's known to be a potent liver carcinogen, so that's why we care about it, and the Food and Drug Administration tracks it. Polycystic aromatic hydrocarbons, alright, are the one that comes from char-grilled proteins and meats, alright. It's generated by the combustion of meat protein against high temperatures like grilling. Right, what happens is they can bind to DNA and form mutations to occur within them. To reduce the risk, they say, to avoid exposure of meat to open flames or hot metal surfaces, you could partially cook your food using your microwave before doing it. Mostly, moderation's okay. You just have to be careful that you're not eating them excessively. Ionizing radiation is another consideration in our environmental factors. Things like X-rays can give us exposure. CAT scans, for instance, give us 300 to 400 times more exposure than someone who just gets a chest X-ray. This is why we have tried to back down from ordering unnecessary medical tests as we used to try and limit people's exposure to radiation. Other things that we tend to forget about, okay, but are still seeing the effects of, right? Bombs, right? The atomic bombs that went off in Hiroshima and Nagasaki. Those exposed people to radiation. It also mutated the exposed people, who then often went on to reproduce their children, who are now in adulthood, and their children's children, who are in childhood, were also seeing increased incidences of cancer because those genetic mutations have been passed on, right? We see with the radiation increases in cancer types like leukemia, especially in adults and kids, as well as thyroid and breast cancer incidence. Right. What happens is when a cancer is exposed, or when a cell is exposed to radiation, it damages the DNA complex. Right. That then can have a bystander effect because it will release free radicals and overproduce them, and those free radicals will then damage neighboring cells and cause an inflammatory response. Right. If we have damage to our cell's DNA, it has one of three fates. One is that it cannot be repaired, all right, and that causes the cell to die. All right, another one is that the damage can be repaired correctly and the cell goes back to normal. Most often what happens is that the damage is misrepaired and then the cell is mutated and it can go on to create cancer. When we look at cancer, we don't have a cure. All right, we have treatments, we have things that we can try and use to eradicate cancer, but we don't know what causes it. We can't specifically treat cancer, right? We can treat the abnormal cell growth and tumors through things like surgery and radiation, right? But we really want to target prevention, right? It's our number one mechanism to try and reduce cancer mortality, right? By finding it early where it's easier to treat. Right? We want to find cancer before symptoms occur, and to do that we use screenings. All right, so when we look at screenings, it's very scientific the way we figure it out. And we use epidemiology, right? The problem is that there will always be those cases, like the woman who gets breast cancer at 26, right? Or someone who gets colorectal cancer at 30, right? Where they fall out of the screening guidelines. But the best we can do for our population is to try and target them based on epidemiology. So for instance, for breast cancer, we know that after age 50, especially as women go past the menopause period, right, they're at increased risk for breast cancer. So we say they should start their mammogram screenings at 50, right? It's recommended every 2 years, because if we look at the time from when a breast cancer cell mutates to when it causes disease, all right, or cancer, it takes about 2 years. All right, so if we screen them with a mammogram every 2 years, we can catch them at some point in that cycle before it gets, in theory, to the metastasis stages. All right, cervical cancer. We know it hits women much younger, so we recommend they start getting screened at 21. All right, now if they're sexually active, remember STDs play a huge role in cervical cancer. They'll start screening them sooner than that. All right, and then we say a pap smear every 3 years, and this is because it takes about that much time from an abnormal cervical cell to mutate into cancer. Right? Depending on their health and age range, and if they've had HPV or not, they may be able to go every 5 years. Right? It all depends, and they should work that out with their doctors. Right? Same thing, colorectal cancer. We see highest incidence after 50. All right? They will also take into consideration for any of these people who have individual cases. So for instance, the woman who is diagnosed in her 20s with breast cancer, right, they're not going to wait till 50 to screen her sisters. Right? They're going to start screening them knowing that their risk is higher. Right? To stage cancer, they use a TNM, or the tumor node metastasis method. Right? We look at the tumor, and then we give each of these categories a number. The higher the number, the higher the stage of cancer. The higher the stage of cancer, and it goes stage 1 through stage 4, means the worse the metastasis is. Right? So for instance, in tumors, no tumor is a 0. Right? A small tumor is a 1. A larger but contained tumor, or encapsulated one, is a 2. A tumor that's large and invading is a 3. Nodes, same. 0, no lymph nodes infected. Lymph nodes in the area, right, adjacent to the cancer site, that's a 1. Lymph nodes in various areas, that's a 2. Metastasis, no growth. Metastasis 1 if it's in an organ, and then they get a score of 2 if it's spreading. Right. We get diagnosis by biopsying the tissue. Right, especially if they have multiple sites, they have to biopsy multiple sites in order to find out what types of cells are in there to figure out where it originated. That helps with treatment guidelines. They can do imaging like X-rays, CTs, PET scans, and MRIs to look at where different sites are impacted in the body. Right, they can do lab tests for different tumor markers. These are examples. Right, like PSA is our common one for prostate. Right, CEA for colorectal cancer, for instance. But these are proteins that are released by cancer cells. Right, so with the thought being that when cancers grow in the body, they release more proteins, and you can track progress with tumor markers. A PET scan is a specialized scan that uses a dye, right? And what the thought is that, remember, these cells have a higher glucose need and higher oxygenation need. The dye is going to be absorbed quickest by cancer sites. All right, these are them in the images. All right, and they'll light up on a PET scan. All right, and this can tell us areas that are impacted with increased cellular growth. The goals of cancer treatment can vary. Right, they have to discuss options with their healthcare providers, look at comorbidities, the patient's desires, to see what kind of treatment options they have. Alright, and we'll pick up with this on the next video.